morning to one and all. My topic is tips and tricks in scleral buckling surgery. At the outset, I'd like to say I have no financial interest in this presentation. Moving on to introduction, it was Custodis in 1949 who first performed scleral buckling surgery for egg matter retinal detachment. It was later in the 1970s that Dr. McNamara performed vitrectomy, and the internal debate of vitrectomy versus scleral buckling has since then been going on. So the question that needs to be asked, is there a decline in the use of scleral buckling for retinal detachment? If so, then possibly why? Is it possible because it requires significant skill and practice? Is it because it requires a higher learning curve? Or does it require exposure of multitudes of cases and multiple opinions from experts? Or is it because the post-operative complications may be more in buckle, as in case of post-op induced myopia, diplopia, or pain, etc.? All that said, the surgeon should offer the procedure that is the most likely to repair the RD in a single session with the least complications and with the best chance that the second operation will be successful should the first fail. Having said this, there are many certain time-tested scenarios in which both buckling and vitrectomy have anatomical and visual outcomes that are comparable. The presentation will be discussed under the following headings. First is case selection. The question to do or not to do scleral buckling in any case is the deciding factor for the outcome of the case. These are some of the indications in which buckle has a favorable outcome. A fresh RD with early PVR, breaks which are depressible and with relatively anterior or not too much posterior locations, retinal dialysis, media clarity, shifting fluid and systemic parameters also play an important role, and there are many instances in which SB is used as an adjunct to pars plana vitrectomy also. Preoperative planning is one of the most important steps in the success to the surgery. It involves doing an indirect ophthalmoscopy with depression of all the quadrants. All breaks must be localized, the amount of PVR graded, the media clarity assessed, and before going into OT, a drawing of the configuration of the RD with the breaks and a proposed plan of management of what segmental buckle, whether the presence of a belt buckle and how many sutures and proposed site of drainage should be kept in mind. Moving on to the steps of the surgery. Even till date, some people use extraction sutures to give good exposure on the lids, and in case of tight orbits, lateral canthotomy may be performed. Hemostasis should be achieved prior to it. Conjunctival peritomy being the next step, is the limbal peritomy is the most common and preferred. I prefer to place diagonal incisions and not at the 180 and 90 because at least the diagonal incisions come under the lid. And possible complications which can occur are conjunctival buttonholing, which should be avoided by grasping tenons and conjunctiva together. And by combining the radial relaxing incisions, conjunctival tearing and shortening may be avoided. And to avoid exposure to the suture, posterior relaxing incisions should be performed. There are selected cases, example in cases which have already undergone trabeculectomy, in which the posterior incisions, that is 5 to 6 millimeters from the limbus, is also done. The next step is muscle tagging, and the possible problems which can be encountered with this step are partial tagging, injury to the vortex vein, and injury to muscle belly and tendon. To avoid all this, do good quadrant clearance, isolate the major blood vessels at the margin of the muscle belly so that the entire muscle width is located, and while tagging, always remain anterior to the equator to avoid the vortex veins. Preferably tag the inferior recti or the lateral recti first, and then last should be the superior rectus from lateral to medial to avoid the tagging the superior oblique. After tagging all the muscles in all 4 quadrants, inspect all the 4 quadrants for ectasia, staphlomas, thinnings and dehiscence in each quadrant, because even at this point, if there is too much of dehiscence, it may not be possible to proceed with buckling and vitrectomy may be required. The most important step for the success of this buckling surgery is localizing the break, and prerequisites to successful localization include good media clarity, pupillary dilatation and a fundus chart in which all the retinal vessels and retinal lesions have been traced out. Always use a closed tooth forceps or an O'Connor localizer. Indent with the tip of the instrument and not the shaft, and start from anterior and proceed posteriorly. While indenting, ask your assistant to steady the globe and mark with a cautery or marker pen after localization. Always keep in mind Linkoff's rules when it's not possible to have visualized the break preoperatively, because intraoperatively may help you to localize the area of the break. In case of multiple breaks, localization should be done in the form of marking the posterior extent of the posteriormost break and circumferentially edges of extreme breaks. Small holes or tears, it's sufficient to mark only the posterior edge, but large holes and flaps, mark on posterior alveolar anterior extent also. In case of dialysis, mark circumferentially at the edges anteriorly, and then the posterior edge is marked. Avoid parallax effect in bullous retinas, as the retina tends to appear more posterior. Some clues which may help you are pigment epithelial changes in the choroid where the proposed possible site of the break should be, or employ the DAC technique also. In case of cryopexy, the next step after localization, it is to produce chorioretinal adhesions. Protect the skin and the conjunctiva while performing cryopexy, and always visualize the tip and indent with the tip and start anteriorly. Do contiguous spots with gentle whitening that should give you good chorioretinal adhesions. Do not refreeze over the same area. Do not apply your cryo posteriorly or blindly. Do not freeze over bare RPA because that may cause more PVR changes or more media haze, and do not apply it to an area of proposed possible cytodrainage. After doing cryo, there should be a measurement of the distance of the break from the ora, and hence the buckling implant should be chose. You have both explants and implants, and they're further classified as asymmetric and symmetric for sponges and encircling bands. The general indications for using a segmental buckle are multiple breaks in 1 to 2 quadrants, or anterior breaks or dialysis, whereas radial buckles are used in large horseshoe tears or posterior breaks. Always remember while choosing the number of the buckle that the width of the radial buckle will depend on the width of the tear, and its length depends on the length of the tear, and conversely for the width of the segmental buckle will depend on the distance of the tear from the ora, and the length of the buckle will depend on the width of the tear. To produce a desirable buckle effect, it should be 30 degrees on either side of the break and anteriorly to support ora and posterior margin of break. For example, if you have a break which is 5 millimeters from the ora, then choose a buckle which will have a 7 millimeter size and place your sutures at 9 millimeters from the ora. Coming to scleral suturing, generally partial thickness sutures are used. It should be about 2/3 depth, placed 3 to 5 millimeters long and parallel to the long axis of the tire. We generally use 5-0 polyester, but polyamide has also been used. And while performing scleral suturing, always visualize the needle tip, start from the center of the quadrant, and then proceed towards the muscles. Posterior sutures should be 3 to 5 millimeters, and try to indent with the curve of the needle so that you're able to do the bobbing technique and pass the suture along on the sclera. Always avoid posterior pressures and always keep visualizing the tip of the needle. Sometimes too much of posterior pressure can also cause bending of the needle, so avoid that also. Finally, the suture should end near the muscle insertions, and after doing this, give a temporary knot. And the next step should be to place the buckle underneath the sutures and give a temporary knot, and then proceed to do an indirect ophthalmoscopy to see whether the break is flat on the buckle and whether the need for drainage is there or not. If there is no need for drainage, then do finalization of your sutures past your belt buckle, and then you can close the conjunctiva. But if there is need for the drainage, then you need to move the buckle aside from the site of the drainage, and then do drainage. Indication for SRF drainage are some of the following conditions: bullous RDs, PVR more than grade B, inferior breaks, aphakics and pseudophakics, high myopia, glaucoma, poor RPE function, and chronic RDs. The principle of SRF drainage involves elevation of the buckle by diminishing intraocular volume. Hence, the retina will settle on the buckle and facilitate closure of the break. To do good drainage, always avoid areas of choroidal vessels and vortex veins. Preferably do above or below the horizontal meridians, and preferably in the posterior 1/3 of the buckle. If it's not possible to do under the buckle, then use a mattress suture and be ready to close the sclerotomy as soon as the drainage is over. Always avoid sites near retinal breaks or cryo marks. You can either use a 27 gauge needle to do direct drainage or use a 10-0 suture needle after doing a choroidal knuckle. Always use cautery to the edges of sclerotomy so that the sclerotomy edges retract and the choroidal knuckle becomes more pronounced. And as soon as drainage is done, please put the buckle over the area of drainage and finalize your sutures. Always monitor IOP constantly during drainage. It can be substituted later with doing intraretinal gas injection or saline. And any fallen IOP while draining should be compensated with not much traction of the muscles, but using cotton tip applicators placed 180 degrees away from the site of drainage. After the drainage is done, then the traction of the suture should be increased. In case of repeat drainage, you can try it through the original site or second site after doing a repeat indirect ophthalmoscopy. Possible complications in drainage are dry tap, retinal incarcerations, and retinal perforations and choroidal hemorrhage. Ultimately, the key to a good scleral buckle surgery is good localization and treatment, selection and placement of a buckle, and doing uncomplicated SRF drainage. Thank you.